It gives me great pleasure to introduce Professor John Van Danker. So John is a professor of pediatrics, pharmacology, physiology, genomics, and decision medicine at George Washington University in Washington, DC. And he also holds the Evan and Cindy Endowed Chair for Pediatric Clinical Pharmacology at the Children's National Hospital. He has held many distinguished positions and received multiple awards, so I'm not going to mention them all now, but just a few highlights. He's held the Distinguished Investigator Award from the American College of Clinical Pharmacology in 2008 and a Lifetime Achievement Award in Pediatric Pharmacology and Therapeutics from the Pediatric Pharmacy Association in 2019. He's published a staggering more than 600 peer-reviewed papers in the field of neonatal and pediatrics pharmacology, and we're delighted to have him here today to share some of his research. Thank you very much, John.
Thank you very much for your kind words, both, and also the introduction by Veronique. What really happened in the past here and still going on. And Caroline, thank you very much for your kind words, and I'm happy that you kept it short. Being in the US, many times happens that the first 10 minutes you tell them what you have been doing, but it's a waste, because the time goes on and it's better to share with each other what we like to have done, but also what we want to do in the future. So I would like to give you some introduction, also because I heard from Professor Wouthuizen, the audience is quite diverse. It's not in your specialty most of the time, and I don't want people to get confused already in the first slide, because I hope that I can keep your attention for at least 45 minutes. So what is clinical pharmacology? And I decided to use the definition of British Pharmacological Society. Clinical pharmacology encompasses all aspects of the relationship between drugs and humans. It's the only medical specialty in the NHS focusing on the safe, effective, and economic use of medicines. It is a diverse discipline that both sustains and advances best healthcare. Clinical pharmacologists are clinicians with training in clinical pharmacology and therapeutics, and their core goal is to improve patient care through the safe and effective use of medicines. Two definitions, pharmacokinetics and pharmacodynamics. Pharmacodynamics is a study of the absorption, distribution, metabolism, and excretion of drugs. In other words, you take a drug, what is your body doing to get rid of it? So I think that's the way to remember it easy. Then pharmacodynamics is the relationship between drug concentration and pharmacological response. That is really the reason why you give a medication. You have pain, you get a medication against pain, and you would like to see pain relief. So that's pharmacodynamics. We still have some therapeutic orphans. We as adults in this room are taken care of quite well. We get studied well, we have medicines where we know the safety and efficacy of, but when you go to pregnant and lactating women and newborn babies, that's a different story, and I'd like to give you that story. A lot of things happened in the past by maternal and pediatric drug history. On the left side you can see thalidomide tragedy, a drug given for morning sickness, primarily in Europe, because in the US, a very smart lady at the FDA said, I don't trust it. And she was right. A lot of children were born with phocomelia, as you can see on the picture, major abnormalities of the extremities, but also all kind of neurological deformities. The right upper part, lithium Epstein anomaly. Women were treated with lithium for manic depression, and unfortunately, that also resulted in very severe cardiac abnormalities for their offspring. And then at the bottom is the diethylstilbestrol DES exposure, given again to try to keep pregnancies going. The issue was, though, that not only the women who get exposed to the medication had more chances of risks during the pregnancies, but also an increased risk of breast cancer, double increase of pancreatic cancer. What even was more worse, their offspring had a big chance of getting clear cell carcinomas of their vagina. So not only the women who were exposed to the medication had issues, but also the girls coming from these mothers had major issues. So we learned a lot by having therapeutic misadventures going on. Then in the middle is the sulfanilamide tragedy. We have still a problem nowadays in medicine, especially in children, is to have an appropriate formulation. When you have a big tablet, how do you put it in a 2-year-old? Then the smart chemist thought, I add diethylene glycol to sulfanilamide. Sulfanilamide was an antibiotic. Clearly, the antibiotics still worked very well, but the diethylene glycol killed a lot of adults, but also primarily children who used this smartly produced elixir. Pregnant women, 1977, the Food and Drug Administration recommended preventing pregnant women from participating in phase 1 and phase 2 early studies. So not allowed to have pregnant women participating. Only in 2020, the first, there's still a guidance, the draft guidance comes on that we need to study pregnant women. And because why should you not study them? Because we're always afraid that we harm them and their growing children. But they're ill, they're also just human beings. It's not because you're pregnant, you're certainly not a human being anymore. They have their issues, and I will show you what kind of diseases are going on. Also, what you need to remember and realize is that pregnancy nowadays are happening, the first pregnancies, not anymore at 22 years of life, but at the end of the 20s or the early 30s. So many, many women already have developed some chronic diseases. So what you can see is the conditions caused by pregnancy, pregnancy-induced hypertension, preeclampsia, preterm labor, gestational diabetes mellitus, depression, infections, pain, nausea and vomiting of pregnancy. On the other side, though, already pre-existing medical conditions like hypertension. Do we want to stop the hypertension medication for the pregnant woman because she's pregnant? Probably better for the fetus perhaps, but not as good for the woman. The same counts for diabetes type 1 and 2. Depression, there has been a big debate. Stop the antidepressants during pregnancy. Better for the outcome of the newborn. Not that good for the pregnant mother, and also then after the nurturing mother, and also not that good for the children. So we learned a lot about that in recent years. Seizure disorders, clearly if you have seizures, for which you take medications, you can't stop that during pregnancy because you get seizures, and seizures can be potentially leading to mortality. Then with cancer, no discussion. Endocrine disorders, substance abuse, autoimmune disorders. In other words, so many reasons that pregnant women take medications. So what we know nowadays is that more than 60% of pregnant women take at least one prescription medication during their pregnancy. More than 90% of approved medications do not have appropriate labeling for pregnancy, resulting in off-label use. As a physician, you have to do something. The patient needs a medication. You don't know the exact information about it, but you can't not treat the patient. So 81% use at least one off-label drug, and 72% use at least one high-risk off-label drug. And I think that's important to realize because of the pregnancy-related changes in the anatomy and physiology, the optimal dosing is for most of these drugs is unknown. And again, unknown dosing and off-label use place these pregnant women at risk for therapeutic failure on the one hand and toxicities on the other hand. So there is quite a moral obligation for us to include pregnant women in clinical studies. At least you have the information that is also available for us being non-pregnant. So what do we know? We know a lot in the meanwhile. These are pregnancy-related physiological changes. And you can see here the differences in protein binding, and not going in details, that would be going too far for this hour. But we need to know that, for instance, renal function is changing. We know, for instance, that liver enzymes, some of them will work faster, other ones will work less fast. You need to know that because the medications are still continuing. You need to realize that, for instance, the renal function is much faster. And why is it important? The next slide shows you that. Imagine you have an infection as a pregnant woman. You need antibiotics. This is an antibiotic that everybody knows, amoxicillin. I'm sure everybody in the room has had it during his or her lifetime. And we know that during pregnancy, the clearance is much higher because the renal function is much faster, because that baby is growing inside the mother's womb. And then you would not know that, or you won't apply that. That means that you undertreat pregnant women in the second and third trimester of their pregnancy. And when it's a urinary infection, they will get pyelonephritis and get much more ill than they should have done. And whereas then after the postpartum, after the delivery, they get back to normal in respect to the clearance of medications. But imagine, COVID was not that far ago. I know that I looked at the professorships here that now at number 44, should have been 45, but one left was not there because COVID was there. Not that long ago. Do you think that pregnant women were allowed to participate in the studies using the medications for COVID? NIH excluded them all. It was too dangerous to do. But they also got COVID, and actually many of them died. So I think we have this obligation to really get rid of these therapeutic orphans that still are very, very much part of this society. What we also know is that in addition to the physiology changes on renal function, metabolized enzymes, we know slowly more about that the placenta is not an organ that doesn't do anything. It's not a passive rabbit. It's a very active organ with transporters, with metabolism, with all kind of issues that play a role that can both transport medications that goes from the mother to the child back to the mother, or keep it to the newborn baby or the fetus in this case. So a lot of things are developing there. Pharmacogenetics is already 20 years around. We don't know much about it yet during pregnancy because we never studied it. So that is changing. Slide that I borrowed from Tamara van Dongen. She was one of my PhD students in my time in Switzerland. Just to have an idea, an indication that I want you to take home. Changes in physiology has changes in how you handle medications. Doesn't matter whether you're a pregnant woman, doesn't matter whether you're a fetus or a newborn. And this is a very busy slide, I'm not going to go through it at all. But if you later want to read it, and just let me know and I can send it to you. But physiology, it's all developmental physiology that has an impact on how we handle medications. That we're using nowadays. So we have now a way of using the physiology to think about, can we predict what happens during the different stages of pregnancy, or when you get 85 plus in age, can we predict how the medications are handled? And this slide shows you that PBPK models are mechanistic models, so they describe the absorption, distribution, metabolism and elimination based upon the underlying physical, chemical and biological mechanisms. Each compartment of the model represents a single organ, as you can see. We always think simple, liver, kidney, that's it. No, all organs have a role. 5 years ago or 10 years ago, I have many of you in the room that learned at school phase 1 metabolism. Everybody thought that's the liver. We know that the intestine is not only important for nutrition or immunology or for all kind of other issues, but for sure also for metabolism and transport of medications. So we also can see now with this modeling that the drug movement is mapped to a physiologically realistic structure. So it's not black box magic from the pharmacology people. Now this is real. You can see there's a human body, there's a part of the blood that goes to the organ, part of the blood that gets out of the organ, and it circulates, and we can really calculate these things. Why is it important? Because the next slide shows you on the left side, such a model. They built different blocks for adults, and I'm not going to give more detail there because then I would take another 2 hours. But what we do nowadays, we use that same model, but then we adapt it for pregnancy-related changes in anatomy and physiology that I mentioned earlier, and also looking at changes in the drug biology and the interaction. So what's going there? So you have the same model built in UME, and now we can use that same model and translate it to the pregnant situation. And that gives us a much better start when a pregnant woman needs medications for the first dose, or for which medication would be best for her at a certain age of pregnancy. So these things are really happening and more coming to the surface. So let's go then to the newborn baby. This is a newborn baby, and of course for many of you this is not something you do see every day. For people in the room who are neonatologists, for sure they have seen it every day, and some of them still see it every day. Normal pregnancies are between 37 weeks and 42 weeks. And these are babies around 23, 24 weeks gestation. You can see the hand of the father, it's a little baby. And despite that, nowadays we can do a lot of them. As you can see, the baby is on the ventilator. You can't see it, but I can show you that here via the tube in the lungs. This is a little tube in the stomach. I'm sorry for that. And here you have, in the umbilical vein or artery, we put a line. We can here measure the blood pressure. So you can see you go to the doctor for blood pressure. There's a little bit bigger manchette to put your blood pressure in. But we have this, all these things are adapted now to the babies. So you can measure blood pressure. And in this area, you can continuously measure the saturation of the blood with oxygen. So to know if you give not too much or too little. A lot of things possible. And of course, a lot of people in the room know that much better than I have been doing that much longer, but I was only interested, of course, always in medications surrounding this. So let's go back a little bit in history. We are in a very historical place, Oxford University. What do you want more? So this is, I think, a nice slide to show, and I do that actually always because I love this slide, and it's because historical drug development, quote unquote. It was a very potent medication. Cop's baby's friend. What do you want more? Colic, diarrhea, cholera, and teething. It worked against everything. And what was in there? Alcohol and morphine. Okay? Then you go to the right side, teething, deodorized tincture of opium, 1.5%. Perfect. And then there's also something about the pain for getting teeth coming through. And that part I have to put my glasses up, but on the bottom stays, satisfies the baby, pleases the mother, gives rest to both. Okay, I'm done as a pediatrician. If I can do that, everybody's happy. It was a little bit too harsh because the rest to both for the babies was permanent rest or death because of the opioids. So this development happened, and I have more to talk about this, but I skip it because I think I go to the next one. Historical triggers, I already mentioned several, but we need to realize that tragedies affecting children have helped us a lot as adults. So what you see here is diphtheria antitoxin in 1901. That was developed in horses, anti-serum, but there was not much regulation. So unfortunately, it worked against the diphtheria, but there was contamination with tetanus. So a lot of patients got tetanus and died of that. What you can see here is clearly that a year later, something happens. There's always in medicine. Somebody drowns, the next day there is something like a little bridge built. The same happened in all these years here. So what happens here, there was a labeling bill organized in 1902 that set the standards and required licensure for pharmaceutical firms making vaccines. Then 37, I mentioned sulfonamide already, and what happened there, the first time safety was introduced a year later after it happened. It required then that drugs be labeled for adequate directions for safe use. It mandated pre-market approval of the FDA for all new medications, so only in 1937. Then thalidomide, that shows you the picture of the unfortunate children, 1961. And then for the first time, so in 62 only, we needed to look at the efficacy of medications. So I can tell you that there are several people in the room who were born before 62, including myself, and I realized that something would have happened. These things could have been easily killed me. That didn't happen, fortunately, but we have to realize that these developments are all based on misadventures, mishappenings in children most of the time. So what is pharmacology in neonates? I'll give you just a few examples. Left side, you see the baby who had trouble with the delivery, and the trouble means there was asphyxia, or circulatory issues or oxygen issues during the delivery. We know now that if you put them within 6 hours for 3 days on cooling, their outcome is better. So that's what we do all over the world, and that's, I think, important. In the middle part, you see it with premature babies, and on the right side, on the bottom, you see a quite large baby. That's a baby born from a mother with diabetes. And this little baby was 5.5 kilograms, so in other words, that's not a normal weight. Normal is around 3.5 for a full-term baby. So you can imagine that this baby is not only large and difficult to deliver, but they have also issues to maintain their blood glucose appropriately, so you need to help them a lot. On the right top, I think that's an interesting baby. You think you know everything. Pregnancy is the same, it's the same mother, nothing is the matter, babies get born, one is red and larger, and one is white and smaller. And intuitively, I'm sure you would say, the red one goes home immediately, the white one you have to have trouble with. It's all the way around. The red one has been having too much blood, has a lot of difficulty circulating, therefore the baby has also, his heart has been working very hard, takes more time to get him back to his parents than the little white one, who probably sometimes only needs a transfusion and then is ready to go. So from the same mother, with the same medications, from the same issue, these things can happen. So just as a few examples, and again, I could fill the whole week with you here, but I'm sure you don't want that. Then we know that there is development done because we can do everything we want as we work. If we are PhDs, MDs, PharmDs, we all do our best to improve care, but you need legislators also to help you doing that. So this is the EMA, European Medicines Agency, that worked 2 decades ago now on trying to get also the newborn babies in the picture. I was fortunate enough already then to be still representing the Netherlands, working in the US, but I was able to be there trying to help, and meanwhile that has developed very well, but it takes a long time to change these issues. And then we also know in the US, that's just appeared a little bit more than a year ago, 2022, there's some guidance now what industry needs to do for newborn babies. So it's very recent. So realize that 2020 pregnant women, they're still working on the final, not the draft anymore, but the final guidance, and newborn babies 2022. Realize in the US in 2012, the first time it was mandated by Congress that you should at least have a neonatologist, so a specialist in newborn babies, at the FDA. Before that, there was no neonatologist at the FDA. So this is 2012. So we're still starting there to really do our best to adopt some of the therapeutic orphans that I mentioned earlier. I put them back here just to re-emphasize that indeed 2020, 2022, it's not I'm talking about a few decades ago. It's all very, very recent that we go into these developments. And many of you who are much younger than I am are going to work in this area and already working in this area. So I think it's an important thing that we know where to be going and we are in the right way, but it takes time. So the medication use is always one of the things. Pediatrics with an X is not a typo. It is in the US, half of the NICUs are owned by pediatrics with an X. And they have a good, wonderful way of documenting and also having an information about what they have been doing. And this was published by Reese Clark in 2007. And what you can see here, that they underlined and bolded two medications. Gentamicin is number one. Of 1,000 babies discharged from the NICUs, 822 got exposed. In other words, you have to be very lucky not to get exposed to gentamicin in a NICU in the US in that time. And I'll show you later on the data from 2018, not much changed. I put caffeine there because caffeine, I'm sure most of you in the room need it sometimes to stay awake. Some of you take it in the evening and won't sleep anymore. Sometimes that's good when you study for your exams, but otherwise it's annoying. Caffeine is used in a newborn baby, and I come back on that in more detail, for apnea of prematurity. In other words, when you're born prematurely, you just sometimes forget to breathe. And that's not that good for your future. And we know that there's people taking care of these patients, and we know that caffeine helps, not always perfect, but there's another reason also why we started to give caffeine to almost all newborn babies. And it was because Barbara Schmid, one of our colleagues, showed almost now 2 decades ago, I think, in the meanwhile, that it gives you a better outcome. And we don't understand why, but it is the way it is, but I come back on more detail because that work is very important. And I had the fortunate time in Oxford already working with the neuroscience team that's here, but also with the chair, Caroline, who works very much on trying to find a better way of using this caffeine in these newborn babies. So I told you 2007, now 2018, is published in 2022. That's the most recent information from the same network. Gentamicin is number 2, but very close to ampicillin. And you see caffeine is number 3, and the days of use is quite impressive. And when you now look to ELBW infants that are extremely low birth weight infants, so the little ones, there you can see that gentamicin day of use is quite high, but what really, really staggers is the caffeine, almost 40,000 days of use of caffeine in these pediatric and neonatal units in the US. And then you would say, if you use it so many times, then we should know how to use it, don't we? Okay. Caffeine, since the 1970s, it's used to treat apnea. I mentioned that it's forget to breathe of the prematurity in preterm infants. Nowadays, all these patients are getting exposed to caffeine, and very often now immediately after birth, and the median caffeine treatment is around 6 to 7 weeks. So in other words, you can say that caffeine is one of the most used drugs worldwide in the preterm neonate. So what do we know about it? Because the pharmacology comes, and again, that's what I love so much to share with you. We know the first days of life, the half-life. What is half-life? Is when you go from 50 to 25, from 25 to 12.5. So you halve the amount of the medication that you can measure in the plasma. When you're in the first days of life, it takes you 120 to 150 hours to do that. So it's very slow. Then a couple of weeks later, it's 60 to 80 hours, and indeed a few minutes later, it's like the same with you and me. Don't talk about the fact that some of you need caffeine because you are a very active metabolizer or a slow metabolizer. That's a completely different ball game. In the newborn baby, in the first weeks of life, it's renal function. The liver is not doing much yet. That has to come still, developmental-wise, physiology. The current dosing is, actually didn't change much in the last 40 years, so therefore I had a smile on my face when I said, if you use it 40,000 days a year, what are we doing? Why don't we know how to use it? So here you see what we do, a loading dose of 20 milligrams per kilogram and a maintenance dose of 5 milligrams per kilogram per day. Jack Aranda, who's still around and active in downstate New York, started that in many, many years ago, and is a good friend and very, very active still in the field. And then Barbara Schmidt, I mentioned her name. And the issue is though, and I put it in white here, this dosing regimen does not consider the dramatic increase in clearance during the first weeks of life, period. And the only thing that changed in these 40 years, from the 1980s, what you wanted to reach as concentrations was 5 to 15, and in 2010 it went to 15 to 20. So the goal, the pharmacodynamic goal, so to say, changed. But the pharmacokinetics, nobody changed it really. So we had some practical questions, and I'd like to share these practical questions because that is close to everybody. Because when you have medications, and everybody in the room, except the young ones, have medications on board, you'd like to know if the doctor knows what he or she is doing. So what is the impact of increasing caffeine clearance on caffeine concentrations if you keep that 5 milligrams per kilogram per day? That's what I showed you. That's done already for 40, 50 years. Then what adjustments are necessary if you want to have a stable concentration? Because if you believe in caffeine, then you would say that this baby has 6 to 8 weeks the same concentration. And then the last question is what peak concentrations are obtained when you give higher loading doses as one of the ways to go to this better goal. I will give you examples. So this is the classical way. 20 milligrams per kilogram, you give out a loading dose, 5 milligrams per kilogram you give every day, and what you can see happening, you wanted the 15, you see on the y-axis the caffeine concentration, PNA stands for postnatal age, so the days after you're born, and clearly after a few weeks already, when you don't change the maintenance, you go below the 15 milligrams per kilogram. In other words, these patients are not treated anymore adequately. That's the current situation in the majority of centers, not only in the US, but across the globe. So what can you do? You can do two things. You can say, okay, I'm going to adjust my maintenance dose. In other words, every couple of days, weeks, you go up, and this shows you that. This is a dosing schedule that we give 6 milligrams in the second week, 7 in the third to fourth week, 8 in the fifth to 8th week, and that way you keep the concentration at the desired range between 15 and 20. Not that difficult, but for people working in hospitals, we know that we can make mistakes. So if you have too many times changes in your dosing, that can also lead to medication errors. So the other option you could do is this. You can give just a high maintenance dose from the start. It's the same loading, but then you don't go with 5, but you go with a double dose. And what you can see here is that in the beginning, a little bit higher than what you really aspire to, but in the 6, 7 weeks, you never come too low. And too low is something we don't want, because when the kids get too low, the chance that they get again breathing sensations is getting higher. And what we do then in clinical practice, we give an extra loading dose, or we do double or twice a day. We are always very magician-like, because there's no guidance. So these are the ways that you can look at these issues. And then this is when you give very high loading doses. Some people got very enthusiastic about it. So 20, 40, 60, 80. And you can see you get to very high concentrations, and you see on the y-axis. And we know that more than 40 milligrams per kilogram gives such high levels that you can have side effects that we don't want to see. Most of the time, newborn babies are very resilient. Tachycardia is a side effect of too much caffeine. That's probably not that good for us. They're not in a good shape. Newborn babies are fantastic in shape most of the time, and their heart rate can do a lot, but there's no need to do so. So in other words, there's different ways to do this. So currently is not sufficient to account for the rapid clearance maturation. Simple adjustments produce constant exposure. And I've showed you that, going up every 2 weeks or at a higher maintenance dose. Nothing complex, very simple. And then, of course, the high loading doses we don't want because of the high expression. So, simple story, simple drug, used 40,000 times dosed every year in the US, so across the globe, 100,000 times. But we don't do it. Okay. Okay, let's go back to the newborn baby, or to drugs in general. So this is a busy slide, don't worry about it too much. I will walk you through this. In red, growth and development. What is unique in our field? And that's also during pregnancy, because the fetus grows the fastest through the whole lifetime. growth and development. Why is it so important? Two things. Your target is moving very rapidly. So when you think you know what you're doing, 2 weeks later, you don't know any more what you're doing. Plus, if you hit the target in the wrong moment, it can have lifelong consequences. So we have quite a responsibility in both the fetus growing in the pregnant mothers, but also in the newborn babies. I have no time to talk about genetics today, but what I want to show you though is that we need to realize that we know something now about the normal development and growth. We don't have normal kids in the intensive cares. They are ill, they're sick, otherwise it would be papa and mama. So we have to still learn a lot about what the disease is doing on all these processes. And we know, for instance, when you have a child in the intensive care with a sepsis, the metabolizing capacity of these patients go to 1/10 of so 10%. So these patients get morphine, midazolam to give them comfort and pain, and they have hypotension because there's sepsis going on. 2 days later, there's still hypotension, but you treat the infection already, so they should be improving. So the hypertension is not anymore of the infection, it's because of the morphine and midazolam, because you should adjust them to 1/10 of the dose, otherwise you're overdosing your patients. So that knowledge has to come and has to be incorporated, and we come back later on that implementation is a challenging task, because most physicians and healthcare workers are very stubborn, and I can say that because I'm one of myself. Okay. Critical role of pharmacokinetics. In adult medicine, we know this. In pediatrics, in neonatology, and in pregnant women, we don't know this. So that's, I want to repeat it again. But again, all these factors are important because that will tell us what is the exposure to the medication. And if we know that, we know how to dose them. Otherwise, it's a black box. We just start something and we think we're doing the right thing, but that might be many times not the case. Just an example, and no exams after this presentation, so don't worry. Oral medications, everybody in the room has taken them and will take them in the future. All these factors play a role. The blood flow to the gastrointestinal system, gastric pH, I'll come back on that later, I've bolded it for you. Metabolism in the bowel, how much intestine do you have? Transport in the bowel, microbial colonization, the motility of the bowel, how fast do you empty your gastric content? And then the biliary function. In addition to that, all kind of pharmaceutical aspects that I don't talk about because that's not my expertise, but that play a role too. The example of the gastric pH, this is a slide showing you on the y-axis penicillin concentration, on the x-axis the time after giving the oral medication to these individuals. Study done in 1953, published, so for most of us, that is, a few of us are born before that age, that year, and what you can see here, that preterm newborns in the dark blue line are able still to get penicillin, given that way in their blood, in the circulation. When you're more than 2 weeks of age, it doesn't work. It's nothing to do really with absorption. Gastric acid and penicillin G don't like each other. So it's going to be completely deactivated. It doesn't work. So therefore other penicillins were developed, and I was glad to hear from Veronique today that Abraham and also actually Newton worked very much in the antibiotic world, and the cephalosporins are developed very much here in this city. We know a lot, and sometimes you have to be a little bit, I don't say the word cynical, but worrisome. This is a paper I was asked to write a couple of years ago. And 1953, I showed you that slide from this gastric pH and gastric acidity. But so many years later, we don't still have no consensus about the ontogeny. How does it happen, the gastric acid production? Both the rate and the amount, and the secretion, or what it does for the impact on the preterm or full-term babies. What happens really there? And we also know very limited still of the effect of age on the rate and extent of gastric emptying in the neonate and during early infancy. So in other words, we have generated a lot of information in all these years with networks everywhere in the world, in the US, in Japan, in Europe, in the UK, but we still don't have this incorporated in our daily practice. This slide shows you something else. This is where we consist of. And I used, of course, my favorite orange color to indicate extracellular water. In green, intracellular water. In gray, protein and fat. In green, in blue. And what you need to realize here is if you're premature or term infant, 80 to 90% of you consists of water. So a good friend of mine, and I always mention him because he's not only a good friend of mine, he's also a very good friend of mine, Karl Aldegaard, always compared his children with jellyfish. So easy to remember. And the last part, I always mention that too, because I'm a prime example of that. People, adult, getting more fat, you can call them calamaris. So that way, you can remember where to put your medications in these youngsters, but also in the people who get older. So by transformation, medications get metabolized, phase 1 step most of the time, different enzymes like cytochromes. I won't go in their details too much today because it's too short. Metabolites are formed most of the time, not sufficient to get rid of them. We do a second phase metabolism step, and then you can excrete them by the urine. So what the take-home message here is also, you can have a perfect liver, a perfect intestine, a perfect brain. If your kidneys are not doing well, you're still in trouble when you take medications. Adults receiving midazolam on the intensive care, midazolam was discontinued because the patient needed to wake up. They didn't wake up because the metabolite was still there and the kidney didn't function well. So these patients, despite the doctors, the pharmacists measured the midazolam was 0, they didn't measure the metabolite and it was sky high and resulted in this continued depression. So you have to be more patient and get the renal function in your system. What do we know about the development on this? I'm going to skip this because of the time also. And this is done by Ron Heinz. He worked on it for many, many years. And different enzymes, and again, you see a huge amount of variation. And the reason why he did it, and I'm going to skip this very fast, is that dependent on whether you're pregnant or non-pregnant, some of the enzymes are more active when you're pregnant. Some enzymes are the same, whether you're pregnant or non-pregnant. But the majority of enzymes hardly exist when you're pregnant, but when you get born, they get active. And clearly these enzymes were not there created for the antibiotics or the medications we're talking about nowadays, but the development is used now very much in predicting how to dose and how to use these medications. Last slide to make you unhappy, I do it on purpose. So I give you an example about things that we really know a little bit about. And we have been working on this for 20, 25 years with many people in the field. But these developments are still going to happen. We know there is transport going on between the different areas, and these transporters are genetically expressed. Some of you will have a fast metabolizing capacity, or other ones a slow metabolizing capacity, the same for the transporters. So we have to learn a lot still, because this is not only in the adults we do the genetic testing, but we in pediatrics, especially also in pregnancy and neonatology, we need to understand still the developmental changes in these enzymes. So not enough work to do for everybody in the room. Renal function development, here you can see on the light microscopy here, the development that you can see here on the pictogram, how from the ureteric blood we make glomeruli. These are the ones that really filter your plasma. Maturation, this slide shows you on the y-axis all kind of units, but what I want to show you with this slide, it's an old one also from 1973, changes in the length, the weight, the renal plasma flow, and also the GFR. And in newborn babies, because that's what I'm talking about also again, we know that these changes are very rapid. I want you to look only at the green bars. The first days of life, you have a GFR, also renal function, of 30, a week later it's 50, a week later it's 70. In other words, what I mentioned earlier, growth and development, your target is moving so fast that you really need to work with teams to understand this and to really get it done in the clinical practice. This is a problem. Two reasons why it's a problem. I've mentioned the name of a person who's not from Oxford, but from Cambridge, but I thought, let's take the chance. So there was a very famous British economist, and he said the difficulty lies not so much in developing new ideas as in escaping from old ones, and I'm going to show you what I mentioned with that. You see here, information of 1993, and again, I'm not going to give you details. It shows that if you're more young, remember the orange bar, you're more consisting of water. So then when you have medications that go into that water, you need to give more. Here in 1993 said you have to give that more to the young patients. Then here, more than 10 years later, we finally changed this. This is Harriet Lane, is more or less, quote unquote, the Bible for residents, fellows, faculty in the US to dose medications. So 1993, we know that we have to change. 12 years later, finally this change is happening, and I want you only to look here. It's not a small change, it's a doubling of a dose. It's not 10% more or less, it's a major change, okay? And then here, 2015, study done here in the UK, but the same study in the same time in the US. What happens with antibiotic guidelines in Europe? They're important. But what happens here is that comprehensive antibiotic prescribing guidelines are lacking in many European pediatric hospitals. Antibiotic guidelines vary significantly in terms of antibiotic choice, bacteria coverage, and recommended duration of therapy. So we know in 1993 that we have to adjust things. 10 years later, we go to adjust things. Then 10 years later, we didn't adjust things. We're very stubborn. Every unit, that's not only in the UK, that's in Europe, that's in the US, that's in Japan, thinks that they have to have their own dosing guidelines. The most easy thing to dose is antibiotics. We know the circuit endpoints. For pain, it's difficult. How do you measure pain in a newborn baby? That's painful to measure that well. But antibiotics, we know, and still we don't get it done. It frustrates me, as you can hear in my voice, and it's also a failure. It's not only frustrating and blame other people, it's also because we didn't do that well. So, future directions. I'm getting to the last part of my presentation, and I hope I don't take too much time, but artificial intelligence, we are in the time, and it was already many years ago here, but now we're going to use it also for pharmacology. So we go to accelerate modeling of clinical data. That's going to happen. I'll give you an example soon too. And it will help us finding the optimal dosing strategy. I will give you an example after this slide here that we know now, based on the artificial intelligence, to start better with the first dose. It doesn't mean that we're there then you still have to do some control what you're doing, but you don't shoot really from the hip anymore. You really start shooting from the shoulder. So I think it's getting better. So this is a slide from an artificial neural network that you can use to do pharmacometrics, so modeling. I showed you that earlier. When you do it by hand or the old-fashioned way, you get data from us, renal function or whatever. It takes you weeks to months to do so. So we had Tamara van Dongen, I showed you her slide. She did that for her PhD. Then now we have Dominique Brehm in Basel, who's doing machine learning, and he did it in a few hours. He got the same data. We didn't tell him anything about the work that Tamara had been doing, and he got the same curves instead of weeks or months' work that Tamara did. She was a hardworking young lady. He did it in a few hours. So that is really changing the speed. And that's academic work. When you go to industry, they're doing this dramatically now because development of new medications going to industry they don't want to lose money. So time is money. So when you're going to use this, they will be much faster going to new products than they have been doing till now. So that's an exciting future things, but the future is now. Then here's just a study we did recently with Shanghai University in China. All this information we have from this baby, you can see about the current weight, birth weight, gestation rates, I can mention all these things there. We know that information. We can then use machine learning to calculate the first dose. Then still, when you get the first medication, we take some blood sample to see where we stand, because everybody is unique, but they are much faster in the right dose. Think about all the patients nowadays who have thrombosis. They get anticoagulants. The biggest issue with anticoagulants is you give too much, so they have risk for bleeding, or it takes too long to get in the appropriate INR. So this is all going to help tremendously to improve that. Then real-world data, real-world evidence. Nowadays, most hospitals have this electronic stuff going on. That's so much information that will tell you the variation in your patients. So the FDA here already said in 2020, they started to fund a pivotal neonatal project supporting the real-world data to generate real-world evidence in neonates. There's INC, stands International Neonatal Consortium, and I know that Charles is also part of that. Critical Path Institute, and a project to support the collection and systemic integration of global neonatal data from the electronic healthcare system. National databases and clinical trials. So in other words, Japan, for instance, has given all the information ready to the network. You can look at this data, you can really go much faster now with these new technical opportunities. And here, this is also used now for just getting normal values in newborn babies, because there's always debate about it. And also natural history disease progression models, for instance, in this case, chronic lung disease of prematurity, of old-fashioned, still called bronchopulmonary dysplasia. Then, in the intensive care, you're never alone. There's nurses around you, there's doctors around you, there's pharmacists around you, a lot of people, family around you. But also you're hooked on all kinds of machines. And so we do a lot of continuous measuring of data. And I'll give you just an example that I got from a good friend from Rotterdam. He's a senior author on this paper. Sino Simons, he did his PhD with me, I think 30 years ago. But now he's helping him, a lot of PhD students. And what this slide shows you is that you can just measure oxygen saturation. That's continuously. I showed a little baby with a little thing around the hand. That's continuous oxygen saturation. And in this case, on the left side, you see the distribution in the patients they studied. There were 60 patients. And on the left side, on the bottom, you see less than 80% saturation. That's too low. In newborn babies, you don't want to be that low, but also not too high, because that's risky for the eyes. But what this slide only showing, that's the only thing you want to remember, is that the left side shows you the distribution before the medication is given, that in this case, doxapram, that's after caffeine. And the right side, after the medication is given. So what you see, hardly any patients anymore in the lower area, and they moved really to the right side just with the medication. That would be ideal. Ideal world doesn't exist, especially not the medicine. So this slide shows you then that there are patients who will react. There's on the bottom on the left side, you see before and after, and patients who won't react. So the responders and non-responders. But just using the saturation measurements that you're doing already for clinical care can help you tremendously to improve this. So I think this is the other step. And then the final step is this one that I got from Caroline and from people working with her. I thought that was also what I learned a lot when I was during my time here. I never thought about what they were doing. So I knew about EEGs and pain measurements because Rebecca Slater was doing that, Caroline was doing it, and the whole team here. But to use this now also to guide caffeine based on the maturation of the patient. So what we do, I talked about the pharmacokinetics. That's simple, relatively. But you give caffeine because there is a reason, because they stop breathing. And that is not to do with the gestational age, it has to do with the brain maturation. And what Caroline and her team is doing now is to measure that and to see if we can really then say, no, you have to stop. These patients can go home without an issue. And it's also going to be a very easy thing to do when you have that developed. And I think it's brand new. It's in preparation, as you can see. But this is going to help a lot also, not only for caffeine, but perhaps for other medications in the near future too. So thank you, Caroline, for sharing that with me. Key points, last 3 slides. Pediatric drug development laws have improved labeling of products, including off-patent products, for use in pediatric patients. In the near future, pregnant individuals and their fetuses, as well as neonates, will get the necessary support to improve their orphan status. That needs to happen. And I'm sure I will be a long time retired when it happens, but you guys here in the room, or young, do it. Dose selection in pediatric patients, including neonates, should be based on understanding the influence of growth and development. I mentioned that, the moving target, on both kinetics, the easy part, and the dynamic part, the more difficult part. PBPK, pharmacophysiological-based PK, and maternal fetal PBPK will be important tools to support clinical pharmacology investigations in pregnant and lactating women, as well as newborns. And again, I think there's been major strides made in establishing consortia, clinical research infrastructure for pediatric patients, including neonates already, but the same needs to happen for pregnant women and their fetuses. And then the use of real-world data, artificial intelligence, machine learning will really help to move. And I hope that 2 things, if you remember these 2 things, I'm happy. The importance of developmental physiology as a determinant of the drug position. It's all physiology. And of course, when you're ill, it's pathophysiology. That's a different discussion. But first, you need to know this. And then to understand how age-related changes in PK and PD will influence dose selection in pregnant women, lactating women. Didn't talk much about that, but they're also completely neglected, as well as newborns. In the long run, we get all these babies here. They go to a difficult time, but this one is looking well at this caregiver. And I hope that many of you never who have a premature baby, but when you have them, there's a lot of people in the world that can get wonderful care of them, and you get the maximum out of them. But you have to be there yourself, because yourself is so important, because in the hospital is hospital. And then I look again to Henry Wouthuizen, because I want to thank him for my wife looked at it, and I've asked you about it, but I thought it was nice, because therefore I found my title. And this was also sad, because Jella Bunte died of a hyperemesis gravidarum, a disease in pregnancy, on a very young age. So, and she said in her book, Jane Eyre, take to his bosom the poor orphan child. And I think we have pregnant women, lactating women, and also newborn babies. They need some caring bosoms for the future to come. And I'm going to thank you very much first, because I think when I stop, then there's an applause, and I don't want to hear it yet. I really want to start by saying thank you to the Edward Penley Abraham Research Fund. I think without that, I wouldn't be here, but many of my predecessors won't be here, and many people to come. Veronique, as chair of the electoral board, thank you very much. Henry, David, Kevin, George, Constantine, Sally, and the members of the editorial board. And then, of course, Lincoln College, and especially again Henry, who was not only a real host for me and my wife, because I still remember Christmas Eve. We had a wonderful glass of wine at your home, and met your grandchild, and being both pediatricians, that was the highlight of the evening. And despite the wine, we were still good in observing, so it was all good. Thank you so much for that. And George, the head of pediatrics, who is busy raising money, and a good excuse not to be here, and he really does it very well. Rebecca, he's talking in Verona. Caroline, Luc, Shaka, Sue, and then my beautiful wife Nutella, and our son John, who turned 26 today, but he is for his work in Miami, so he couldn't be here. So thank you very much for your time. I hope it was not too much. If there's anything questions later on or now, don't hesitate. I'm reachable. I will move on, but I promise to keep on teaching the medical students, and that has been approved for years to come, as long as they don't get bored by me. And I will keep my relationship, of course, with the team of Rebecca and Caroline and Luc and the others in the room. Simon is there, and Marianne is there. Okay, thank you very much.